Thank you, Professor. So I think no question, but everyone's going to visit the website and register for a Congress.
Thank you very much. And I'll continue, and I would like to invite again from Thailand, Professor Supakoru Rojananin, and he's a professor and consultant in the Department of Surgery, Faculty of Medicine in Bangkok, and former Secretary General of Royal College of Surgeons of Thailand, and probably many other functions. And he's going to talk about surgical patient safety, Thailand experience. So please, Professor.
Good afternoon, Mr. Chairman, Co-Chairman, ladies and gentlemen. Thank you very much for the organizer and Prime Hospital to invite me to Dubai. I think Dubai is a very amazing city that man can ever create on earth in the 21st century. I would like to present about the surgical patient safety activity, what we have done and what we are doing and what we are going to do in the next time in Thailand. First of all, I would like to present the background of the healthcare in Thailand. Thailand is a small city in the country in the Southeast Asia, about 65 million people. We are under universal coverage for healthcare. That means that every Thai can have an equal accessibility and for the fundamental health service throughout the country by paying just only 30 baht or $1 for a visit. We have about 4,000 doctors in 2012, but because of the uneven distribution of the doctor, the distribution is about 1 to 700 population in Bangkok to 1 to 3,000 in northeastern part of Thailand. The capacity for producing medical students about 2,500 a year. There are 22 institutes that offer medical teaching program nationwide. All about 44,000 doctors. You can see that doctors who are under 40, women doctors are more now than men. As you see, the more younger the woman become a doctor. And for the surgeons, it's about 10% of doctors become the surgeon, not including orthopedics or an ENT surgeon. We have 1,000 public hospitals and 315 private hospitals as registered in the Ministry of Public Health in 2012. As you can see that Faculty of Medicine Siriraj Hospital is the first and oldest established since 1888. We have 2,300 beds, 2.8 million outpatient visits, and we have a medical staff about 800 staff, medical student about 300 per class, and resident fellow about 375 per year. At Department of Surgery, we include 9 divisions: general surgery, vascular, trauma, head, neck, and breast, plastic surgery, cardiothoracic, and urology and neurosurgery. As you see that in 1997, the Thailand suffered from economic crisis that we call Tom Yam Gung crisis or soap bubble break. At that time, the people are seeking for more transparency, more accountability, and looking for the quality control in all institutes, including hospitals. So Healthcare Accreditation Institute was established in 1999. And Siriraj got the first accreditation by hospital accreditation in 2001. At that time, Bamrungrad Hospital was the first private hospital to get international recognized for standard of JCI, followed by Bangkok Hospital. And recently we have 38 JCI accredited hospital, and Sirilat Hospital was the first university hospital who get the JCI accreditation. Now, for a surgeon to err is human. We admitted who never do wrong are those who do nothing. So the patient harm due to medical mistakes can be catastrophic, and some cases result in high-profile consequences, not only for the patient, not only for the institute, but also for the surgeons like us. Because of the multiple level of the mistake, ignorance, the last victim who undergo wrong will be the scapegoat, who will be blamed and punished. After some books published about the patient safety, like Schwartz Principle of Surgery, I have put the patient safety in the chapter 12, that we all know that is a standard textbook for our surgical training. So most of the surgeons now become recognize the patient safety as a topic of concern to all surgeons. We have the clinical lead team, which is the multidisciplinary team that looking responsible for the quality improvement in surgical care, including surgeon and anesthesiologist, nurses, pharmacists, work together in multidiscipline. This is the occurrence report that we have to monitor in every year and every month. You can see that the retained foreign body, allergy to any kinds of drug, wrong size surgery, and wrong patient surgery, and also other usually occur in my department. The same as in 2012, the incident is happening occasionally. So after in 2010 we have one sentinel event about the misplaced catheterization in the man, and would have a very big consequences. So we come to see the root cause of analysis, and we found that most of the men nurse aide had lack of knowledge and skill about how to place the catheter properly. So we refreshing the course of training of the catheterization to men nurse throughout the hospital in 2010, and then we do the OSCE examination in 100% of those. There will be no, after that there is no incident ever reported until recently. This is the first that we have to set up the risk management team in our hospital. The risk team conference, we have the conference every Thursday morning at 7:30 morning, and talking, discuss, and find the cause of sentinel event and everything that has an adverse effect to the patient in every week. And these teams will run automatically, not influenced by chairman of department or any person. We learn and we analyze and we find the new system approach, and we how to cascade to the site of the to the all level of the healthcare personnel to accept the new process. So we also award for the good occurrence report that makes a better change. Like we have the foreign body we retain foreign body in the lumpectomy patient for the instance. to accomplish the patient safety policy in the institute level, we think that the leadership is most important in every hospital, that need to be side by side for us and support everything, even the budget, to promote the campaign of the patient safety. And then we need to create the patient safety in your hospital and put the good process and good system, and then we learn from what we are doing or others' mistake. Non-punitive or no-blame system is is a good thing that we encourage the report of the incident, and we have to do it very timely and confidentially. I think all of that is a passive. We think that it's a passive way to improve the patient safety, because we wait until the mistake happens and then correct it. Is it about time to go for the proactive way to prevent it? So if we looking for the standard or good surgical practice, we will have the three categories. The standard of competency, that means knowledge, skill, experience, decision-making, continuing professional development, and the standard of care, and also the standard of conduct. We launched the good surgical practice in our country in 2009, modified from the Royal College of Surgeons of England. For the standard of the competency, we have the training program by Royal College of Surgeons, and most of the surgeons, all of these surgeons have to qualify by Royal College after 4 to 5 year training, and then followed by 1 or 2 years for fellowship training to ensure that all the surgeons will have their competency throughout their life. Continuing professional development was setting up in 2014 to gather all the activity together and put a good system for monitor and oversee the quality of our membership. For the standard of service, we launched the WHO surgical checklist in 2010. At first time, we launched introduced the checklist to our department. It was banned by powerful surgeons because they said that it's useless to use that. Do no wrong already. So to see that the senior surgeon usually are very powerful, and if they say no, it means no. As you see that we have this surgical checklist have 10 objectives. You already know that. The challenge is how to create the culture of safety and implement the checklist in our country after we have been banned. So we are convinced that this surgical checklist is a proactive manner to prevent the surgical mistake. So we asked surgical-oriented department to collaborate: orthopedics, ENT, anesthesiologists, ophthalmo, OBGYN, and OR nurses to come together. We also convinced the hospital administration to announce the patient safety policy. We convinced the related loyal colleges, society to launch a mutual agreement or declaration of the implementation of the checklist. And also we acknowledge the public, social media, to act as a social pressure to our institute too as well. Until March 2012, we declare by our colleague the patient safety and we have the public hearing and press conference about that. Healthcare Accreditation Institute and 7 surgical-related royal colleges or Nurse Association declare a commitment to adopt the WHO checklist, surgical safety checklist, as a tool to improve the surgical patient safety in March 2012. After that, we make a strategy planning to disseminate the checklist from local to regional and then to the whole nationwide. At this time, we will forget the dead wood first and focus for the new generation. That means we focus mainly on the surgical training center first. For the surgical training center, we have the 26 institutes throughout the country, located in Bangkok, 14 hospitals and 12 in other regions. We set up a year plan to organize the surgical patient safety workshop around the country through the collaboration of the Royal College, International College of Surgery, University, OR Nurse Society, and Hospital Accreditation Institute to have the workshop in Bangkok, in Northeast, in North, in South, and Eastern part of country. Like first organized in Bangkok, and then to the Southeast, to the Northeastern part of Khon Kaen University with 24 provincial hospitals involved. We learned that some of the provincial hospitals had done the checklist long before the college declarations. And then we go to the north with 14 provinces joined together, and then to the south, and then to the south with more than 200 participants, university, and the southern hospital in the country. We also have present our workshop and our plan in Taiwan in 2013, and also we come to present our work in Bangalore in India, and also here. And then we set up the tool for external peer reviewer to re-accredit 25 training institutes that we launched the project. The specific aspect for patient safety goal to be assessed by Royal College include the policy of the patient safety, the process, and the key performance index. All the 25 training centers will be reassessed and will be first include the patient safety policy as one of the items for re-accreditation of these training institutes. Key indicators include wrong surgery, drug allergy, surgical site infection, increased wound, retained foreign body, and wrong or missing specimen should be 0. At Siriraj Hospital, the compliance rate after the checklist has been launched, you see that the first month we have the compliance only 35%. That's very low. But we try to encourage all the division to move on until at the end of the year, the compliance rate becoming over 95%. As you can see that the general surgery and vascular surgery division had the lowest compliance at the first time. Now we are launching the modified early warning sign, including sepsis, limb ischemia, postoperative increased intracranial pressure, and postoperative bleeding after open heart surgery for the trigger tool to monitor the patient before having a full-blown incident of these. Now in this year, we also summarize the 10 commitments for surgical patient safety to all surgeons to follow that include response to emergency, patient identification, medication reconciliation, hand washing, informed consent, and then to discharge summary, discharge planning. And we put our policy to everywhere in the department. Also, we launched the 10 commitment about ethical, legal aspect to the surgery as well. So in what we are doing after we have the good surgical practice in 2009, and we launched the surgical patient safety checklist, and we are looking for the sustainability of the patient safety policy. So now we are going to encourage all the hospitals in the nation to put the patient safety policy and launch the patient safety program in the curriculum of undergraduate level in all medical schools in the country. Thank you very much.
Thank you very much. And is there any question to the talk? Anyone wants to ask anything? It's a very important topic, of course, but so no questions. Thank you very much.